Assalamu alaikum wa rahmatullahi wa barakatuh. In this lecture, I will talk about the portal vein and the portosystemic anastomosis. In the portal venous system, a capillary venous bed is drained into another capillary bed before going back to the heart. It allows direct transportation of substances from one organ to another without spreading them all over the body. The portal venous system usually refers to the hepatic portal venous system, through which the venous drainage of most of the gastrointestinal tract plus the spleen and pancreas pools into the portal vein to reach the liver before returning to the heart through the inferior vena cava. This way, all substances absorbed through the gastrointestinal tract, including nutrients, toxins, and pathogens, are first processed in the liver before they can reach the general circulation. The liver acts as a gatekeeper to the body. It serves two main functions. First, the liver processes the nutrients and regulates the amount of them that can enter the blood. The second, it serves as a detoxification organ. Thus, the liver screens the blood for potentially toxic substances and pathogens and removes them before they can reach the rest of the body. Now, what are the structure, location, beginning, termination, and tributaries of the portal vein or hepatic portal vein? Portal vein is present in the upper right quadrant of the abdomen. It is valveless and generally reach 8 centimeters or 3 inches in the adults. It begins behind the neck of the pancreas. Here in the left figure, part of the pancreas is removed to see the beginning of the portal vein behind its neck by the union of the superior mesenteric and splenic veins. Then the portal vein passes in the free margin of the lesser omentum behind the hepatic artery and the bile duct. It terminates at the hilum of the liver or the porta hepatis by dividing into right and left branches to the right and left lobes of the liver. The branches divide into smaller and smaller branches and then breaks up into capillaries that running in the portal triad between the lobules of the liver, as we mentioned before. These capillaries lastly drain into the tributaries of the hepatic vein, through which they pour blood into the inferior vena cava, the general circulation. The tributaries of the portal vein include right and left gastric veins, superior mesenteric vein, splenic vein, and cystic vein. Right and left gastric veins drain the lower end of the esophagus and part of the stomach. Superior mesenteric vein drain the part of the stomach, small intestine, and large intestine till the right 2/3 of the transverse colon. Splenic vein drain also part of the stomach, spleen, pancreas, and distal part of the large intestine. Lastly, the small cystic vein drain the gallbladder. Liver receives 3/4 of its blood supply from the hepatic portal vein, and the other quarter from the celiac trunk through the proper hepatic artery. The portosystemic or portocaval anastomosis is a collateral communication between the portal and systemic venous system. Blood flow in healthy individuals is as follows. We have three major sites of portocaval anastomosis. First, at the lower end of the esophagus. The esophageal veins can drain blood either to the azygous vein or to the gastric veins. Through the azygous vein, the blood passes into the superior vena cava and directly to the heart. But through the gastric veins, the blood passes to the hepatic portal vein, traverse the liver, then back to the heart. So at the lower end of esophagus, there is a collateral or portocaval anastomosis between the left gastric vein and the azygous vein. The second site in the abdominal wall, where the veins around the umbilicus may drain into superficial gastric veins, superficial epigastric veins into the great saphenous vein, then into the femoral, external iliac, and to the common iliac, then to the inferior vena cava, directly to the heart, or instead blood can pour from paraumbilical veins to the hepatic veins, to the hepatic portal vein, then traverse the liver and back to the heart. So in the abdominal wall, there is anastomosis between the paraumbilical veins and the superficial epigastric veins. The third site in the lower 2/3 of the rectum, where the blood drains into the inferior rectal vein, then to the internal pudendal vein, where it is joined by blood from the middle rectal vein into the common iliac vein, then to the inferior vena cava. The upper part of the rectum drains into the superior rectal vein, then to the inferior mesenteric, then to the splenic, and to the hepatic portal vein. The blood traverses the liver and again to the heart. So in the lower 2/3 of the rectum, there is anastomosis between the superior middle rectal vein and the inferior rectal vein. The hepatic portal pathway may be blocked by a variety of causes, which are classified into prehepatic causes, for example, thrombosis or congenital obliteration of the portal vein. Hepatic causes, for example, lesion in the liver like liver cirrhosis, and post-hepatic causes like congenital stenosis of the hepatic veins. If obstruction occur Due to any of these causes, the portal venous pressure rises, portal hypertension, and the collateral pathways open up between the portal and systemic venous systems. When the pressure elevated and venous enlargement occurs, this enlargement occurs mainly around the sites of portosystemic anastomosis, and this is called esophageal varices if it occurs in the lower end of the esophagus, or caput midose if it occurs at the umbilicus, or hemorrhoids if it is occurred at the lower end of the rectum. Esophageal varices are susceptible to trauma, and once damaged may bleed profusely, requiring urgent surgical intervention.